Right now, it's important, I think, to consider patients that you're wanting to initiate therapy for in terms of selecting the appropriate therapy for those patients. There are some factors that we're using right now. First thing to consider is whether or not they have 17p deletion, because we know chemoimmunotherapy doesn't work for 17p deletion. Those patients should be treated with an ibrutinib-based therapy. For patients who have a mutated immunoglobulin gene, if they're younger and fit and able to tolerate chemoimmunotherapy, then FCR is the standard, should be the standard of care for those patients, and those patients should be interested in FCR-based clinical trials, because we've observed that about 2/3 of them, 50% to 2/3 of them, may be cured with their first-line therapy with FCR. And that again is younger patients fit who have a mutated V gene. For the younger fit patients who have an unmutated V gene, or the elderly group, that's sort of where there's a lot of options right now, and physicians and patients need to have a discussion about, what the treatment objectives are. Do they want to consider a treatment where they're getting several months of chemotherapy or chemoimmunotherapy, a remission, a treatment-free period, and then likely repeat treatment several years down the line? Or do they want to commit to going on an oral agent that they need to take continuously without interruption and indefinitely until it doesn't work any longer? And that's a harder discussion. In terms of the research that we're doing in the clinical trials, for those populations, the unmutated V gene patients and the elderly patients, we're very interested in the small molecule inhibitors and combining them or sequencing them to try to achieve the same effects that we can see with chemoimmunotherapy. So there's a lot of work in that area also.